Starting systemic bacteriology, gram positives. Now, bacteriology in systemic bacteriology, gram positives bacteria, they can be gram positive cocci or they can be gram positive bacilli. Okay. Now, if we have to divide gram positive cocci, so gram positive cocci can be divided on the basis of catalase. They can be catalase positive or catalase negative. If they are catalase positive, then that has to be Staphylococcus. If they are negative, then they will be Streptococcus. Okay. So, gram positives, gram positive cocci, gram positive bacilli, catalase. Among gram positive cocci, how you are going to differentiate catalase के basis पे catalase positive, then staph. If it is negative, then strep. Okay. Then gram positive bacilli. Gram positive bacilli will be catalase negative or strep. A gram positive bacilli. Bacilli, most of the bacilli they produce spores. So gram positive bacilli they can be spore producing and they will be either spore not producing. Now amongst those which are spore producing they will be classified according to the oxygen. So they can be aerobic or they can be anaerobic. If it is an aerobe, then it will be, if it is gram negative, gram positive bacilli which produces spores, which uses oxygen, then it is is an aerobe. Then they are bacillus. If uh, gram positive bacilli spore producing but not consuming oxygen or anaerobe, in that case it is Clostridium. So Clostridium is actually gram positive but it is an anaerobe. Okay, and it is also spore producing. The type of spores they produce bulging spores, whereas Bacillus the spores are non-bulging spores. Now oxygen. Again, this spore gram positive bacilli which are spore producing and which do not produce spores, but they can be aerobic or anaerobic again. So these are non-sporing but gram positive. So non-sporing gram positive aerobes are Corynebacterium, Nocardia, Listeria, and Mycobacterium. Corynebacterium, Nocardia, Listeria, Mycobacteria. These four. Okay, CNLM or C, we can remember it alphabetically. It is Corynebacterium C, then LMN. This is Listeria, Mycobacterium, and Nocardia. These are aerobes, but they do not produce spores and they are gram positive bacilli. Then again, gram positive bacilli which do not produce spores and they are anaerobic. Okay, so anaerobic gram positive bacilli which do not produce spores and are also anaerobic, they include only actinomycetes. Okay, actinomycetes. So now what is the template? In general, all the bacteria will be covered under the following headings like introduction, then cultural characteristics like selective medium, how is the colony morphology. We are going to talk about the virulence of the organism and after virulence, clinical features, investigation of choice and drug of choice. Okay, investigation क्या कराना है उस particular bacteria में, what is the drug of choice for that particular bacteria, all this. So let's begin with staph aureus. Okay, but before that I discovered something very nice in this textbook of mine which I used in second year MBBS, and I did not use it then, but as now lot of clinical questions are coming, so I thought every bacteria has a clinical case heading written in this. So I'm going to read every case clinical scenario with a particular bacteria. For example, first clinical case given in Anant Narayan is a 56-year-old man developed skin abrasion on the hand while working in a garden. Okay. After 4 days, he noticed the swelling and inflammation over the area of abrasion. So after 4 days, we noticed swelling and inflammation over the area of abrasion, followed by swelling of his hand. So there was a purulent discharge from the lesion after another 2 days. A gram stain of the discharge and culture on the blood agar were positive for gram-positive cocci in clusters. So what does this show here? Stafford. The patient was found to have a strong family history of diabetes, and so he was investigated for this as the possibility of spread to deeper tissues and to the bloodstream existed. On further testing, this bacteria was identified as Staph aureus, and antimicrobial susceptibility showed resistance to penicillin and sensitivity to clostridium. Okay, so this is how uh, this whole thing just tells about Staph aureus. So there can be Staph aureus which are resistant to penicillin, but they are sensitive to clostridium because resistance is very common. Then second clinical case is a 15-year-old boy returned from a birthday party and began vomiting 6 to 7 hours later. There was no fever and the boy passed loose stools. So without any fever, the boy is passing loose stools after going to a birthday party, and especially the time is 6 to 7 hours. The next morning, he rang up his school to inform him that he could not come that day. When the teachers let him know that 6 other children who had attended the party had reported a similar illness, on further questioning, the common dish that all the affected children had consumed was found to be pineapple pastry. This pastry was recovered and the cream tested positive for Staph aureus. So the teacher thought कि ऐसा क्या हो गया that everybody started suffering from the same disease, and this pastry was recovered and the cream tested positive for Staph aureus. Now, further investigations found that a specimen obtained from the nose of the cook was also positive for Staph aureus. Both were ascertained to be the same type by fast typing, and the pulse field gel electrophoresis was done. This indicated a common source as well. So now moving on to Staph aureus. Staph aureus, they are gram-positive cocci. They will be arranged in clusters. Coagulase positive, then Staph aureus. If it is coagulase negative, then they are called as coagulase negative Staph aureus. In that case, what antibiotic you are going to differentiate and further classify? Novobiocin. Novobiocin sensitive or resistant. If it's novobiocin sensitive, then it is epidermidis. If it's novobiocin resistant, in that case it is Streptococcus. Okay, so Staph epidermidis it's a skin commensal, so that forms a biofilm, and it's also present prosthetic. It is associated with prosthetic valve infectious endocarditis within 1 year. So apart from this epidermidis, IV drug abusers may be yoga. Pseudomonas also is associated with the same scenario, but staph is overall more common, and epidermidis is within 1 year prosthetic heart wall endocarditis will be with this. Then resistant. If it is resistant, then we have an alternative diagnosis as saprophyticus. Okay. Staph epidermidis, staph saprophyticus. UTI in young women is due to staph saprophyticus, and we do a PYR testing in this. This staph saprophyticus that causes cystitis UTI in young women, it is also called as honeymoon cystitis. Okay. So Now Staph aureus और AU का मतलब है gold. Okay, so selective media is Ludlam medium या mannitol salt agar. Okay, then golden yellow oil paint colonies will be found. Now there are certain virulent factors. What are they? Protein A, it attaches with the Fc portion and it escapes from the immune system. So this protein A is a virulent factor. ये Fc portion से attach कर जाता है and by this way it escapes the being recognized by the immune system. Cytolysins can be present alpha, beta, gamma. Now beta is also associated with hot-cold phenomena. Hot in the sense that there will be hemolysis in hot, that is at 37 degrees Celsius, and they will be visible at 4 degrees Celsius. Now, what is visible at 4 degrees Celsius? Let me just find it. Um, virulence. Yes. Cytolysins. Cytolysins. Yes. So, beta hemolysin is a sphingomyelinase, hemolytic for sheep cells but not for humans or rabbit cells. It exhibits a hot-cold phenomena. Okay, the hemolysis being initiated at 37 degrees Celsius, as I said, but becoming evident only after chilling. So the visible thing is that the hemolysis is going to occur at 37 degrees Celsius, but hemolysis will be visually appreciated only at 4 degrees Celsius. Okay, so that's hot and cold phenomena. Gamma hemolysin. Gamma hemolysin is what? Now, gamma hemolysin is just another, is composed of two separate proteins, both of which are necessary for hemolytic activity. And there is also a delta hemolysin that is mentioned in the book, and it has detergent-like effect. So, like, we can forget that. Now, PVL. PVL is Panton Valentine Leukocidin. Panton Valentine Leukocidin is what? Now, this is leukocidin is also a two-component toxin like gamma lysin. Being composed of S component and F component, such bicomponent membrane active toxin have been grouped as synergohymenotropic toxins. This is another toxin. Okay. Now produces exotoxin. All super antigens, exotoxins, they are going to act as super antigens. Now they can be exfoliative toxin that causes staphylococcus scalded skin syndrome. The severe form is toxic epidermonecrolysis and Ritter syndrome. Okay. Mild form causes bullous in petigo and pemphigus neonatorum. So mild form bullous in petigo and pemphigus neonatorum, whereas staphylococcus skin syndrome and Ritter's is for the severe cases. Okay. Now, this line, milder forms pemphigus neonatorum, bullous in petigo, is directly from an antimoron. Now comes enterotoxin. Enterotoxin A2X. Okay, these are preformed toxins. Okay, enterotoxins are preformed toxins. Okay, a bit about, I want to know about this enterotoxin thing. Yes. Now, a word about it is, enterotoxin is responsible for the manifestations of staphylococcus food poisoning. Okay, nausea, vomiting, diarrhea within 2 to 6 hours after consuming food contaminated by preformed toxin. The toxin is relatively heat stable, resisting 100 degrees Celsius for 10 to 40 minutes depending upon the concentration of toxin and the nature of the medium. About 2/3 of Staph aureus strains grown in carbohydrate and protein foods secrete toxin. Meat and fish or milk and milk products cooked and left at room temperature after contamination with staph for enough time for the toxin to accumulate are the common items responsible. The source of infection is usually a food handler who is a carrier. Illness is usually self-limited with recovery in a day or so. 8 antigenic types of enterotoxin are currently known. They are formed by toxigenic strains singly or in a combination. Toxin is believed to act directly on the autonomic nervous system to cause illness rather than on the GI mucosa. So it acts directly on the ANS. Toxin is antigenic and neutralized by specific antitoxin. Type A toxin is responsible for most cases. Sensitive serological tests such as latex, agglutination, and ELISA are available for detection of toxin. Toxin is potent. Micrograms can cause illness. Some cases of post-antibiotic diarrhea are caused by enterotoxin forming staph. Uh, the toxin also exhibits pyrogenic, mitogenic, hypotensive, thrombocytopenic, and cytotoxic effects. Okay, so this is it. Now, enterotoxin again is a preformed heat-stable exotoxin. Incubation period is 1 to 6 hours and it is associated with salads. Vomiting is a predominant feature, so vomiting is more predominant as compared to diarrhea. Antibiotics should not be given because it is self-limiting. But toxic shock syndrome, it spreads through vaginal tampons and it acts as a super antigen as well. Sunburn, rash, DIC, coma, death, profuse watery diarrhea, all these can be caused by toxic shock syndrome. Treatment for all these things is clindamycin. Now, TSST acts as a super antigen by V beta TCR. Now, enzymes. As I said, coagulase. Coagulase enzyme can be free coagulase or bound coagulase. Now, amongst the coagulase, free coagulase is tube coagulase. In this clot reactivating factor, they form clot reactivating factor like DNase, staphylodorinase, hyaluronidase, phosphate, tellurite reductase. Bound form is what? Bound form will have slide coagulase. They have clumping factors. Okay. Whereas the tube they had clot reactivating factor. Bound will have clumping factor. Okay. So that was all about this free and bound coagulase. Then there is something called as soft pain. Soft pains is a mnemonic for the diseases caused by staph. Soft pains में S stands for Staphylococcus scalded skin syndrome. Then O is for osteomyelitis, F is for food poisoning, T is for toxic shock syndrome, P is pneumonia, A is arthritis, I is infected endocarditis, especially native valve endocarditis, most common. Then N is necrotizing fasciitis. The first case was just like this. It's also seen in IV drug abusers, most commonly surgical site infections or skin infections. All of them, you know. Penicillin beta lactamase. Okay, penicillin's beta lactamase is an enzyme and there is resistance. Example, methicillin beta lactamase resistant enzyme. MEC-A gene produced by bacteria. So such bacteria are called as MRSA, methicillin resistant Staph aureus. Now they are given vancomycin, so VAN-A gene. Okay, now if they are resistant to, or if the virus has VAN-A gene, in that case they are resistant to even vancomycin. And then there are two types of antibiotics that can be given in vancomycin resistance, linezolid and naproxen. Okay. Actually, more can be given. I don't remember a bit. Now, going to see certain pictures. This is staph. This is staph. See bacteriophage typing of staph. This is a phage typing in staph. And this is tube coagulase test, that is positive. And negative, this is light coagulase test. Remember, in tube we had staphylodermase, etc., etc. So many things. Slide में we had clumping factors. So because negative में there is no clumps, positive में there are clumps, and I think that is it. No word about treatment. I don't know. Strains resistant to vancomycin and teicoplanin, they are still not here. That is the only thing written. Treatment of carriers by local application of suitable antibiotics such as mupirocin and antiseptics like chlorhexidine. In resistant cases, rifampicin along with other oral antibiotics. So this was all about it. Now we move to streptococcus. Now biofilm formation was seen in staph epidermidis, remember. Micrococci, I'm saying. These are like staph only, but they appear in tetrad form. Moving to streptococcus. Streptococcus, is there any clinical case written? Yes. But there are cases for Streptococcus pyogenes. But let me just read the case for Streptococcus pyogenes as well. The first case is a 7-year-old girl presented with severe sore throat and fever up to 39 degrees Celsius for the previous 3 days. Sore throat and fever, okay. Denied coryza or earache, okay. 3 दिन से आ रहा है, okay, fine. On examination, she was found to have bilateral tender submandibular lymphadenopathy, enlarged tonsils, pharyngeal exudates, throat swab. Culture was performed and the results were pending. She was started on oral penicillin. Culture after 24 hours was positive for beta hemolytic colonies, which were gram-positive cocci in short chains on smear and sensitive to penicillin. Okay. Girl was diagnosed with Streptococcus pharyngitis. Okay. Fine. Next is a 9-year-old girl developed fever and sore throat, and group A streptococci, they were cultured from her sore throat. Okay, group A. She developed pain and tender swelling of both the knees and the ankles. Okay. A palpable effusion of the right knee was drained and yielded straw-colored fluid. Culture of aspirate was negative a few days later. Girl began experiencing shortness of breath. Physical examination and chest X-ray suggested mild congestive heart failure. The girl was diagnosed with acute rheumatic fever. Okay. Murmur was audible at the cardiac apex on follow-up after 1 year. Okay. Rheumatic fever was type 2. Rheumatoid arthritis was type 3. Hypersensitivity. Then third case is a 7-year-old boy developed skin infection but his mother did not seek any medical help. He passed colored urine. 4 days later, he developed pithing edema in both the ankles. On examination, the boy was found to have elevated blood pressure, 4 plus proteinuria, red blood cell counts, and elevated serum creatinine. The boy was diagnosed with nephritis, acute post-streptococcal glomerulonephritis, with a skin manifestation. Remember, skin and pharyngeal manifestation, anything can be there. So, very interesting. Let's go on with it. Let's see the theory of all the strep. See, Streptococcus, the gram-positive cocci, the catalase negative, exist in the form of chains. There will be hemolysis. Okay, alpha, beta, delta hemolysis. Alpha is partial hemolysis, Streptococcus viridins, and Streptococcus pneumoniae. If there is Streptococcus pneumoniae, patient is going to present with rusty sputum. Complete hemolysis is based on carbohydrate in the cell wall, that is Lancefield classification. Complete hemolysis, beta. Hemolysis is complete based on carbohydrates in the cell wall. There is based on the presence of carbohydrates. Lancefield classification is given. So Lancefield classification is based on carbohydrates. This was a question in some GT. Then they are divided into A and B, except I and J, the whole classification is from A to B. And gamma is there is no hemolysis or enterococcus. Okay. The enterococcus shows such characteristic. Now group A streptococcus, group A beta hemolytic streptococcus or Streptococcus pyogenes. These are what group A beta hemolytic streptococcus or Streptococcus pyogenes is actually flesh-eating bacteria. So they are flesh-eating bacteria. They have hyaluronic acid capsule, polymyxin, and neomycin. Fusidic acid, crystal violet, blood agar. Transparent medium is Pike's medium. Lancefield grouping was given by Todd-Hermit reaction. Exotoxin superantigen is staphylococcal pyogenic exotoxin or erythrogenic toxin if the fetus is not in India. If the fever is not in India, then it can lead to scarlet fever, that is sandpaper rash will be seen, strawberry tongue. The diagnosis will be made by streptozyme test. Hyaluronidase, there is a spreading factor. Spreading factor होता है hyaluronidase. Streptokinase and dornase, they have a thrombolytic properties. So they can be used in the treatment of DVT and MI. Streptolysin, it is immunogenic, ASO titer more than 200 international units. That is significant recent exposure. There has been a significant, if there is a significant recent exposure, then ASO titer will be more than 200 international units. Then M protein, yes, M protein is not phagocytic, it is in fact antiphagocytic. And there will be, and on the basis of this, Griffith typing is done. 80 types, more than 80 types of strep can be found. So out of these things, these 1 to 5, they are all enzymes. But M is a protein, M protein, that is M protein of Streptococcus. It mimics certain components of the myocardium. For example, CHO, that is carbohydrate, hyaluronic acid, peptidoglycan, and cytoplasmic acid All of them, they mimic cardiac valves, for example, carbohydrate, antigen, synovial fluid, hyaluronic acid, synovial fluid. Cytoplasmic is glomerular vascular intima, and peptidoglycan. Peptidoglycan will be skin. That's it. Now, types of lesions. The types of lesions can be suppurative or non-suppurative lesions. Now, suppurative lesions can be in the throat or they can be in the skin. If in the throat, the most common cause of bacterial pharyngitis is Streptococcus. It is also known as strep throat, and it causes what? Ludwig's angina. Ludwig's angina is due to Streptococcus pneumonia. Then skin. Skin, most commonly there is impetigo, that is cold sore, erysipelas, cellulitis, necrotizing fasciitis, or flesh-eating bacteria. Now, non-suppurative will be rheumatic fever and post-streptococcal glomerulonephritis. There is a sore throat in this, in ARF. It is, any strain can cause this. There should be genetic predisposition. Penicillin prophylaxis is given. It's a type 2 hypersensitivity reaction and is associated with a bad prognosis. Post-streptococcus glomerulonephritis, skin more than sore throat. So skin infections will be more as compared to sore throat. Okay. So skin infections more than sore throat. Post-streptococcal glomerulonephritis means skin infections will be more as compared to sore throat. Few will have M49, M53 to 55, M19, 12. Few of them causes. And post-streptococcal glomerulonephritis is caused by M49, 53, 55, M19, and M12. So the case scenario had skin involvement first. So skin and then sore throat. See, the case was a 7-year-old boy developed skin infection, but his mother did not seek medical help. Now anybody can get affected. Penicillin prophylaxis is not required. You are going to go for type. It's a type 3 hypersensitivity reaction. PSGN is type 3 hypersensitivity. Why? Because there will be immune complex deposition. So that is the reason. Then it is associated with good prognosis because we have steroids that we can quickly give to these patients. Now comes diagnosis. How we are going to diagnose it? Bacitracin sensitivity and PYR testing. PYR testing, we were doing PYR testing for novobiosine as well. I think so. Yes, for Saprophyticus we were doing Staph Saprophyticus. Yes. So types of lesions. What are the types of lesions? We discussed these types of lesions. Now diagnosis is also about treatment. Treatment will be cephalosporins more than penicillin. If resistance is there or cure short, then we are going to go directly to cephalosporins. Group B Streptococcus is actually Streptococcus agalactiae. It is a commensal in the female genital tract and it causes neonatal meningitis, both in that is in the early, that is within 7 days, early neonate, and also late neonate beyond 7 days. Now, hippurate hydrolysis is done. It is diagnosed by hippurate hydrolysis positive test. CAMP test will be positive. And over here, CAMP is not cyclic AMP, but it is Christie-Alkin-Munch-Peterson test. It is going to increase the beta hemolysin activity. So you see camp test, you see a butterfly appearance. The treatment is again the same, cephalosporins more than penicillin. Then comes enterococcus. Enterococcus, it produces gamma hemolysin, 40% bile soluble maybe, and it has a pH of 9.6. It grows in a pH of 9.6 rather, and at a temperature of 42 degrees Celsius, and it is extremely halophile. See, 6.5% of salt meat grows. It causes what? It causes hospital-acquired infections. So, hospital-acquired infections are caused by this. For example, wound infections, pneumonia, UTI, diarrhea, infective endocarditis, and meningitis. So, hospital-acquired infections are caused by enterococcus like wound infections, pneumonia, UTI, diarrhea, infective endocarditis, and meningitis, enterococcus. Then diagnosis. Diagnosis is bile esculin hydrolysis, that will be positive, and PYR test. Drug of choice for this is vancomycin. If it is resistant to vancomycin, we can go for linezolid and daptomycin. Then Streptococcus viridans. Now, viridin streptococcus is a commensal in the oral cavity, okay, and it also produces a biofilm. See, any organism that produces a biofilm, there is a very high chance that that organism will be resistant. It causes prosthetic heart valve and infective endocarditis, and beyond 1 year of age. So it is Streptococcus viridans. Another one that we read earlier was staph epidermidis. But that was within 1 year, and this is beyond 1 year. Again, the drug of choice will be cephalosporins more than penicillin because high chances of resistance to penicillin. Streptococcus pneumoniae, yes, it is associated with rusty sputum, and it is gram-positive diplococci that is going to exist in pairs, and it is lanceolate or flame-shaped. Carom coin or Droughtman colonies are seen, so they show autolysis also today we read. Now, what are the virulent factors and what are other virulent factors? So, virulent factors are what? Polysaccharide capsule AVMS, that is antiphagocytic virulence, and mucoid colonies, and they have serotypes. They are polysaccharide capsule as well. Other virulent factors is autolysins. Yes, this is autolysin and pneumolysin. More than 95 serotypes they are available. What are the causes? The causes are it causes poems. This is we are talking about Streptococcus pneumonia. Yes, and it is going to cause poems. P for pneumonia, O for otitis media, E for epiglottitis, M for meningitis, S for sinusitis. Meningitis is caused by 3 people, B-A-L, okay, Bell. Group B Streptococcus, early and late, okay. Group B Streptococcus is what? Agalactiae, early and late, yes. And E is by E. coli and L is by Listeria. Listeria causes quite late, that is more than 5 years of age or something like that. S is sinusitis, you know. Now, diagnosis. Diagnosis for capsule, you can have Q-lungs reaction. For CSF, you can have antigen detection or latex agglutination test. Okay, antigen को detect करेंगे या फिर latex को agglutination test करेंगे. All this can be done on CSF. For vaccine, yes, vaccine is available. In less than 2 years of age, we give PCV13. Pneumococcal conjugate vaccine is given. less than 2 years. But more than 2 years, we are going to give PPV or pneumococcal polysaccharide vaccine 23. Now treatment is penicillin and cephalosporins. Anything can be given to such patients. Now there are certain point of differences between Streptococcus pneumoniae and Streptococcus viridans. Firstly, Quillon's reaction that will be shown by Streptococcus pneumoniae. Optogen sensitivity will also be shown by pneumonia. Bile solubility will also be shown by Streptococcus pneumoniae. And inulin fermentation will also be shown by Streptococcus pneumoniae. Viridans will be negative for all. But both of them, they cause alpha hemolysis. So there is a green zone of hemolysis on the blood agar. A green zone of hemolysis on blood agar will be formed. So with this we finish Streptococcus. Let me just go through any images that are there in this chapter. So there Streptococci will give up an arrowhead appearance. With B will give a butterfly appearance. Okay, and remember with B is actually a energy. See Enterococcus, it has oval cells arranged in pairs at in angles or in short chains. I'm going to read two more cases for Streptococcus pneumoniae for better understanding. A 60-year-old man was brought in with history of high-grade fever with chills and rigor. 60-year-old history of high-grade fever, chills and rigor for previous 2 days. He also had mild chest pain and productive cough. There was mild chest pain and productive cough. He was brought in with history of high-grade fever with chills and rigors. For the previous 2 days, he also had mild chest pain and productive cough. Sputum was submitted to investigations. X-ray chest showed consolidation in the right lobe of the lung. This is the lung, so left lobe and the right lobe. The right lobe में consolidation. The direct smear observed after gram staining showed pus cells with gram-positive lanceolate diplococci clinching to Streptococcus pneumoniae just by the morphology we can, or colony characteristic we can come to the diagnosis. Okay. Then sputum culture after 24 hours was positive for gram-positive bacteria growing as greenish colonies on blood agar. Greenish colonies on blood agar. The patient was diagnosed with pneumococcal pneumonia. Antibiotic susceptibility after another 24 hours showed the organism to be sensitive to penicillin, to which he responded. Another case is a 5-year-old child was brought to the emergency department with history of seizures. Okay, there was a history of seizures. Okay, 5-year-old. Yeah, seemed to be Listeria, but okay. Following high-grade fever, he also had 1 to 2 episodes of projectile vomiting. On examination in the hospital, he was found to have altered sensorium, neck rigidity. Kernig sign was positive. A lumbar puncture was done. CSF cytology showed high counts of polymorphs, okay, and biochemistry showed low glucose and raised proteins. Biochemistry chemically that showed low glucose in lumbar puncture. CSF cytology showed high counts of polymorphs, and biochemistry showed low glucose and raised proteins. Low glucose and raised proteins. And gram smear showed the presence of gram-positive diplococci. Okay. Low glucose raised gram-CSF cytology showed gram-positive diplococci. Some of them inside were polymorphs. They were inside polymorphs. The culture was positive for alpha hemolytic colonies on was positive for alpha hemolytic colonies on sheep blood agar. As typical Rotman colonies, yes again, and where catalase negative, okay, optocin sensitive, suggestive of S pneumonia. Patient was started on penicillin and responded to treatment. This is a gram smear pneumonia in preparation. Streptococcus pneumonia colony sensitive to optocin. Quilang reaction, see there is negative, quilang is positive. With this we finish. Coming over to Bacillus anthracis. Bacillus anthracis. So the clinical cases, a 45-year-old veterinary surgeon presented with black eschar on the left hand. It's the right hand, so he presented it on the left hand. Okay, fine. There was extensive swelling around the ulcer, but it was not painful. There was swelling, but the ulcer was not painful. There were few vesicular lesions surrounding the ulcer. Okay. A 45-year-old was presented with black eschar, left hand, extensive swelling around the ulcer. See, for example, this is the ulcer. Very extensive swelling, but it was not painful. Okay. There were few vesicular lesions surrounding the ulcer. He presented a history of injury to the hand while handling animals. Okay. The fluid from the vesicle was positive for gram-positive bacilli. Culture was positive for Bacillus anthracis, establishing a diagnosis of cutaneous anthrax. The patient responded to amoxicillin. Okay. Now, Bacillus anthracis is gram-positive, spore-forming, is aerobe, it's non-motile, it is non-hemolytic. Okay. Polypeptide capsule. There is a polypeptide capsule. glutamic acid capsule is present, and McFadden reaction is also present. Polypeptide glutamic acid capsule is present. There is the reaction called as McFadden reaction. Polysaccharide capsule means a polypeptide capsule, glutamic acid. On gram staining, you see a bamboo stick appearance. Okay. On biopsy, you see boxcar appearance. Okay, there is a medium that is used, special medium is polymyxin, lysozyme, EDTA, and thallus acetate or P-LET medium. On looking through the eye, you can see frosted glass appearance. On microscope, you see medusa head. Okay. So, medium used on looking through the eye is frosted glass, and on microscope, you have medusa head. Okay. On looking through the eye, frosted glass appearance will be seen. Frosted glass appearance. And on microscope, you see medusa head. In stab culture, you are going to see an inverted Ferti appearance that just shows that it is aerobic in nature. Then you have, wait a minute, I think my timer just stopped. Okay. So there was an inverted Ferti appearance in the presence of penicillin. There was what? String of pearls appearance. String of pearl appearance will be there in the presence of penicillin. Fine. What are the toxins produced? Toxins produced, the toxins are plasma mediated. That leads to lethal factor that causes necrosis. There is an edema factor that can lead to increase in the CAMP production, and there is a protective antigen that it can be used for the preparation of vaccines. Now, a diagnostic specimen can be blood, biopsy of the lesion, CSF, all can be used, and PLET medium. But spores can be demonstrated only in medium. Okay. It causes cutaneous HR, central necrosis, and peripheral inflammation. Okay. Then it causes malignant pustule, malignant pustule. It can cause Hyde-Porter's disease. It can cause pulmonary anthrax, that is Wool's-Waters disease, cerebral anthrax, intestinal anthrax, and it is also a bioterrorizing agent type A. Now, drug of choice is what? The drug of choice is ciprofloxacin and penicillin. What is the drug of choice? It is ciprofloxacin and penicillin. Drug of choice is what? Ciprofloxacin and penicillin for 60 days. Vaccine is only for people under risk. Drug of choice is ciprofloxacin or penicillin, and it has to be given for a period of 60 days. Ciprofloxacin and penicillin, and it has to be given for a period of 60 days. 60 days is like extremely too much, 2 months. Vaccine is given only for people under risk. प्रोटेक्टिव एंटीजन से जो derived होती है. Stern vaccine is actually spore vaccine for cattle. Now Bacillus cereus, it is also a type of bacillus. It is motile and it is hemolytic. Okay, वो non-hemolytic था. It causes food poisoning. Fine. Chinese and fried rice, early and delayed. Early is emetic type, delayed is diarrheal type. Early is 1 to 6 hours and delayed is 8 to 12 hours. It acts just like staph का enterotoxin and delayed जो है it acts just like the labile toxin of E. coli. Okay, labile toxin of E. coli. Medium is what? Now labile toxin of E. coli कैसे act करता था? मेरे ख्याल से वो कैम्प प्रोड्यूस करता था और जो वो वाला होता था that is stable toxin. Stable toxin was producing camp. And let me check. I am not that good in general. Okay. Yes. Camp was labile toxin. Yes, camp produce करता है. जो labile toxin. Heat stable toxin produces cyclic GMP. Labile. See, labile will be like a camp, no? Base. Produces anthrax, cholera. Protein synthesis EF2 was Pseudomonas and Diphtheria, and 60S was Shiga toxin. Due to RNA and also E. coli का labile toxin. Oh my god. Now, next is medium. Medium is will be what? Medium of Bacillus cereus is MYPA. Mannitol, egg yolk, polymyxin, phenol, red agar. ठीक, ये क्या होता है? पेम्बा मीडियम भी बोलते हैं इसको. And treatment is by vancomycin and ciprofloxacin. ठीक, यहाँ पे पेनिसिलिन दे रहे थे, यहाँ पेनिसिलिन नहीं देंगे, मतलब बैसिलस एंथ्रासिस में हम पेनिसिलिन दे रहे थे. Okay, so I am just quickly going to go through his book. Bamboo stick appearance will be seen on gram. Staining medusa head will be seen on nutrient agar. Inverted for the appearance. Macpathine reaction. Now, this is cutaneous lesions of Bacillus anthracis. Malignant pustule भी कहते हैं इसको. As bioterrorizing agent, it was used by Al Qaeda. Okay. Anthracoid bacillus is what bacillus? Okay, Bacillus cereus, yes. Bacillus cereus, okay. Nothing as such. Nothing important. We finished this. We are going to move to Clostridium now. Clostridium. Okay, so Clostridium, I am going to begin with first case scenario, and I'm going to subsequently see if there is any more case scenarios. Then Okay, there are no case scenarios, only one. A 50-year-old man had a road traffic accident while traveling in a remote village area. He sustained multiple fractures with open wounds in the left leg. On reaching the nearest hospital 2 days later, he was found to be in shock. The wound was contaminated with soil and blood. The local muscles appeared to have been crushed. He was started on supportive therapy and antibiotics, but after 2 days, the edema and pain at the site increased and a serous discharge developed. When the area around the wound was palpated, crepitations were found. Okay. Microscopic examination of the wound discharge showed the presence of thick brick-shaped gram-positive bacilli, brick-shaped gram-positive bacilli, along with gram-positive cocci. Okay. Based on provisional diagnosis of gas gangrene, immediate surgical treatment was carried out. The exudate was also inoculated into Robertson cooked meat medium and cultured for anaerobic bacteria, which was positive for Clostridium perfringens and Streptococci. Now, extensive excision of the local part had to be carried out to prevent further spread. So, moving on, let's see. Clostridium. Clostridium is gram-positive, anaerobe. Okay, it is going to form spores. All the Clostridium, they are motile except Clostridium perfringens and Clostridium tetani type 6. All are non-capsulated except Clostridium perfringens. So Clostridium perfringens tries to be a rebel in the whole family of Clostridium. So that is why this is the scenario over here. It is non-capsulated. Robertson cooked meat medium is the medium that is used, and the treatment is what? Penicillin. Earlier, the treatment was anti-toxins. So, first you are going to give penicillin, and then you are going to go to for antitoxins. Now, first is Clostridium difficile, antibiotic-associated pseudomembranous enterocolitis. Third, cephalosporins. Okay, the third generation cephalosporins, they cause this. Another one is fluoroquinolones, then clindamycin. All these, they cause antibiotic associated pseudomembranous colitis, enterocolitis. After the 5th day of admission, it causes diarrhea through what? A type and B type, A enterotoxin and B cytotoxin. Diagnosis, toxin will be diagnosed by ELISA and toxin gene will be identified by PCR. PCR is the gold standard. Now, what is the drug of choice? The drug of choice is vancomycin. If earlier it was metronidazole. Okay, but vancomycin is given. We read a lot about this. At an end, we went on reading about this in DVT. There was some technique as microbiota also. Okay, never mind. I want to see Clostridium, not tetani. I want to especially see Clostridium difficile. Yes, Clostridium difficile. Vancomycin and dacitracin, and earlier it was metronidazole. Yes. Chalo. Then comes Clostridium botulinum. See, Clostridium botulinum में you have A, B, C1, C2, D, E, F, and G. These are all what? These are the serotypes maybe. In this A, B, C is a neurotoxin. D, E, G, F is also neurotoxic, but C2 is enterotoxic. They are going to decrease the release of acetylcholine. So what are the diseases caused by it? The diseases caused are, number one, wound botulism. Okay, wound botulism is the disease that is caused by this. Then it is due to spores. Then food-borne diseases, canned foods and Tetra Paks, they contain preformed toxin or exotoxin. Wound botulism is due to spores. Now, what is common in wound botulism and foodborne botulism? It is diplopia, it is dysphagia, it is dysarthria, it is constipation, it is descending type of paralysis. Remember, there will be no diarrhea, but there will be constipation. Okay, and there will be descending paralysis. There will be decrease in the deep tendon reflexes. Then infant botulism, again it is caused by spores. What is the source? Source is honey. That is the reason why children should not be given honey. The only reason is it causes infant botulism. Okay, less than 1 year old children should not be given honey. Then causes floppy baby syndrome or flaccid paralysis. What is the treatment? It is penicillin or antitoxin. Then Clostridium perfringens or Clostridium welchi. This is non-motile. It possesses a polysaccharide capsule. Therefore, it is antiphagocytic, virulent, mucoid serotypes. Serotype A, B, C, D, E. Toxins will be alpha, beta, gamma, theta, and eta. Alpha is due to alpha toxin and it has what? It has lecithinase activity. It has lecithinase activity. Alpha toxin has lecithinase activity. Beta toxin is due to theta toxin. I don't know what does that mean. Then it causes target hemolysis. There is stormy fermentation of litmus milk. Stormy fermentation of litmus milk. That is, it coagulates the milk and clot is broken by gas production. Okay. It causes reverse camp positive test. That was making butterfly, so what is it going to make? Burfi or what? Now, Nagler's reaction is positive. That is, alpha toxin has lecithinase positive activity. So this is the Nagler's reaction time. See, this part of the petri dish contains antitoxin and another half. There will be opalescence due to lecithinase activity. Plate has an egg-based medium. What it causes? It causes gas gangrene, myonecrosis, flesh-eating bacteria, Streptococcus after Streptococcus pyogenes, even this is. Now this is due to serotype A. Necrotizing enteritis or pig bell. Yes, pig bell is due to serotype C. Remember pig bell, very commonly asked. It is due to Clostridium welchi, pig bell. It was either in VR with you videos or either in DAMS infectious diseases unit. Somewhere I read about it. Necrotizing enteritis, pig bell, it is due to serotype C. Now, treatment is by penicillin and antitoxin in the initial stage. Then comes Clostridium tetani. Clostridium tetani, there will be drumstick appearance. Okay. So Clostridium tetani will have a drumstick appearance. Neonatal tetanus is due to Clostridium tetani, and it is called as eighth day disease. Fifth disease, parvovirus B19 slapjack appearance. Sixth disease was some infectiosum, I think, Pyridema infectiosum, something like that. No, Coxsackie virus was sixth disease. Shayad. Fifth, eighth day disease is neonatal tetanus. Okay. Now, motile. Motile, yes, they are motile. Clostridium tetani is motile. They show swarming motility in the medium and stately in and stately motility otherwise. Stately motility was also shown by Bacillus cereus. Then puncture wound is produced. Then it causes Clostridium tetani. Then titanospasmin, it decreases the release. This is a toxin that is produced and it decreases the release of GABA and glycine. Okay, and it causes trismus and opisthotonus. Treatment will be tetanus toxoid or tetanus immunoglobulin. Now, when you are going to give tetanus toxoid or TT कब देंगे? TT tetanus toxoid is available in the form of TD. TT should be replaced by tetanus diphtheria toxoid. This is an update. The ultimate date was 2020 to begin using diphtheria toxoid. A booster dose has to be given when the person turns 7 years or greater than 7 years. Okay. So with this, we finish Clostridium. Quickly going through this chapter and see if any images, types of spores, Clostridium tetani, Clostridium Perfringens. Okay. Gram stain of Clostridium perfringens in gas gangrene. Note the absence of spores. So gas gangrene वाले जो होंगे, that is not going to cause, will not have spores. Okay. This is a Nagler's reaction. This is reverse scan test. Tetanites have a drumstick appearance. Okay. Moving on to Bacterium Diphtheria. Now there is a clinical case question here. A 5-year-old child presented to the pediatric outpatient department, which is pediatric OPD, with a history of pain in the throat. Okay. And difficulty in swallowing. Fine. He had high grade fever for the previous 2 days. Okay. On examination, he was found to have Cervical lymphadenopathy and the tonsillar pillars were covered by a white discharge. Mother was informed that her child's immunization was not complete. A throat swab was collected and submitted for microscopy and culture. Albert stain showed the presence of rod-shaped bacteria. Albert stain showed the presence of rod-shaped bacteria. Okay. Albert stain showed the presence of rod-shaped bacteria. Uh, that is green in color along with bluish black granules. Albert stain showed the presence of rod-shaped bacteria. Okay. Green in color and along with bluish black granules. There were bluish and black granules. A diagnosis of diphtheria was made for the presence of rod-shaped bacteria. Fine. Albert stain, green in color, along with bluish black granules. A diagnosis of diphtheria was made and passive immunization along with antibiotics started. The antibiotics were also prescribed to close sibling and completion of vaccination was advised. Okay, so this gives so much clue to your and depth to what we are studying. So Corynebacterium diphtheria. Now Chinese letter pattern होता है इसका. Palisade appearance भी हो सकता है. Palisading is just remember the palisade cells SSS जो होता है. Klebs, Loeffler's bacillus. It produces metachromatic granules, volutin granules, babes or nest granules, and polar bodies. Okay, so it produces all these things. Okay, metachromatic granules, volutin granules, babes, earth nest granules, and polar bodies. How are they demonstrated? They are demonstrated through Loeffler serum slope, LSS. Yes, remember this was a question today in one of the DAMS infectious diseases wala lecture. Albert stain, Ponder stain, Neisser stain for 6 to 8 hours. Now, potassium tellurite agar was the medium used, and it is modified, and then it was known as Tinsdale or McLeod. Tinsdale and McLeod, these are the two mediums that are actually the modified form of potassium tellurite agar. 48 hours later, black colored colonies are produced. Just remember, we remembered in this clinical scenario, they were talking about black colored colonies produced. Biotypes, what were the biotypes? Gravis, intermedius, and mitis. These are the three biotypes. Gravis will have daisy head colonies. Okay, now intermediate medius will have frog egg colony, and mitis will have poached egg colonies. Okay, so it's actually GD if MP. GD if MP, or that's how I remember. I have written a mnemonic if GD Yadav is PM. If GD Yadav, just one of my professor's name was GD Yadav. So if I and F, I is intermediate and F is frog egg colony. G is gravis and D is daisy. M is mitis and P, that is PM is again poached egg and mitis. So that's how I have written it. Okay. Then we have toxin. See, this is the toxin could be diphtheria toxin. Toxin production is mediated by phage, and that will be a lysogenic phage. or diphtheria toxin, the toxin production is mediated by phage lysogenic is the method by which this was produced. Low iron concentration is needed for the production of toxin. So you should not put a lot of iron in it. A has an enzymatic action, B has a binding action. These are the actions of toxin subunits and the actions of toxin. They are going to act on the elongation factor and inhibits protein synthesis. What? EF2. Targets किसको target करेगा? Myocardium को. Okay. Adrenal gland and nerves. What is it going to cause? It causes diphtheria. Diphtheria is very fatal. Laryngeal diphtheria is very fatal. Now, there is common form of diphtheria is pharyngeal diphtheria. Pseudomembranous tonsillitis. Okay, Clostridium difficile causes pseudomembranous colitis, whereas pseudomembranous tonsillitis is caused by this diphtheria. Bull's neck will also be caused by this. And bilateral adrenal hemorrhage can be caused by this, and there can be myocarditis as well. Now, different mechanism of action of cholera and pertussis toxin. See, pertussis A and B component जो होता है, it causes ATP ribosylation of GI permanently and permanently disables the GI. Therefore, it interferes with the transfer of signals from the cell surface to the intracellular mediator system. So that's how it permanently paralyzes the GI. Whereas cholera toxin also has A and B components. It also causes ADP ribosylation, but cholera causes ADP ribosylation of GS, not GI. So it is going to activate adenylyl cyclase, and once adenylyl cyclase will be activated, it is going to lead to increased production of CAMP. CAMP will cause what? It will cause efflux of chlorine and water. CAMP activate होगा, water or chloride will be effluxed. There is persistent activation of adenylate cyclase. As a result, if because of the efflux of water and chloride there, the patient gets in cholera, patient gets, rice water stools or very, very bad form of diarrhea. इसमें ऐसा नहीं होगा. Now, diagnosis of this diphtheria. See, early diagnosis is by throat swab culture. We just saw that in a pediatric OPD. We had throat swab culture done. Toxins. Toxin may Elix gel precipitation test is one of the tests that can be done. Elix gel precipitation test is a test that is done. Then you have ELISA and PCR. ELISA, PCR can also be done. So Elix gel precipitation test is for toxin, and ELISA PCR can be done. Now, what is the treatment? Treatment in this will be erythromycin and anti-serum, out of which anti-serum we are going to prefer. Okay. What is the vaccine strain? Vaccine strain is Park-William 8 strain. That is the vaccine given for diphtheria. Park-William 8. Erythrasma. What is erythrasma? It is caused by Corynebacterium minutissimum. Okay, erythrasma is by minutissimum. Opportunistic infection by Coryne is Corynebacteria jichica. Corynebacteria ureolyticum. It causes UTI. So UTI अब तक हमने कहाँ पढ़ा? सबसे पहले Staph saprophyticus. ठीक है? That was causing honeymoon UTI. Another UTI we will study in E. coli part. This is Corynebacteria urea lytica. Okay. Going through the book, and I'm going to check if there is anything. See, gravis was what? G and D. D was daisy egg colonies. Yes. Intermediate was frog egg, and mitis was poached egg appearance. Yes. Yes. Corynebacteria on Albert stain. You see this. Black colored on green wala. LX gel precipitation test was for toxins. See precipitation line positive control. Test showing toxigenicity. This is a filter paper soaked in diphtheria antitoxin. Filter paper soaked in diphtheria antitoxin. This is a negative control. And I don't think anything else can be asked. Jacum was opportunistic, no? Minucitimum was what? Erythrasma. Stratum corneum का होता है axilla और groin will be affected. Diphtheroids is Corynebacteria resembling C. diphtheria occur as normal commensals in the throat. Yes, these are going to occur as normal commensals in the throat. Other coryneiform bacteria. Okay. Besides the genus Corynebacteria, a number of other genera of coryneiform bacteria have been defined. Among them, the genus Propionibacterium. We read about this in Derma. It causes what? It causes acne. P. granulosum and P. avidum are constantly present on the human skin. Corynebacterium parvum, which is frequently used as an immunomodulator, is a mixture of Propionibacterium species. So this is also done. Now we are going to move to Listeria. Another bacteria is Listeria. Listeria कहाँ है? Listeria. I am always confused between Listeria and Legionella. Okay, let me just try and find Listeria monocytogenes. It is 395 and another one is at 624, 395 page number. Okay, Listeria monocytogenes. Now there is no case scenario. Why there are no cases? इस साइड में तो डॉक्टर का दिया है but not for other. हेलिकोबैक्टर का है क्या? हेलिकोबैक्टर का भी केस दिया है बट इसका केस नहीं दिया है. चलो ठीक है देखते हैं. Okay. Let me read an introduction. Listeria monocytogenes is a short, non-sporing, gram-positive bacillus. It exhibits a characteristic slow tumbling motility when grown at 25 degrees Celsius but is non-motile at 37 degrees Celsius. This is because peritrichous flagella are produced optimally at 20 to 30 degrees Celsius but not at 37 degrees Celsius. It is aerobic or microaerophilic. Growth is improved when cultures are incubated at reduced oxygen tension and with 5 to 10% of carbon dioxide. It grows best between 30 degrees Celsius and 37 degrees Celsius, but slow growth occurs even at 4 degrees Celsius. So colonies are hemolytic on blood agar. Listeria monocytogenes ferments glucose maltose, L-rhamnose and alpha-methyl D-manocyte producing acid without gas. It is catalase positive and it grows in the presence of 0.1% potassium telluride and 10% salt at a pH of 9.6. Okay, just a nice background. And I am now no more confused between Listeria and Legionella. Okay, Listeria. Gram-positive tumbling motility also exhibits differential motility. Yes, we just read about it. Low temperature पे will it be motile? No, it was not going to be. No, a low temperature पे it was motile. Like अगर ठंड होती है तो हम we can walk, but if it's hot, we don't feel like walking. We feel like sitting at one place. Okay. So high temperature, 37 degrees Celsius, it is non-motile. What does it exhibit? It exhibits endotoxin activity. Okay. Endotoxin activity exhibit करता है. Okay. Cold enrichment, 4 to 8 degrees Celsius, maybe it can grow. It is present in food items, for example, cheese. So if you think you can keep your cheese safe in a refrigerator for a very long period of time, then my friend, you are mistaken because that can act as a source of Listeria monocytogenes. Okay, so Listeria monocytogenes can grow in there. Toxin is Listeria toxin. In semi-solid medium, okay, it produces a turbidity. Now there is a medium called as Palcum medium. Umbrella turbidity will appear. Polymyxin, acryofulvin, lithium, ceftazidine, esculin, and mannitol. These are the things. It causes neonatal meningitis, granulomatous infantiseptica, okay, neonatal meningitis and granulomatous infantiseptica. So all the diseases will occur in the child. That means if the mother had consumed a lot of ice cream and lot of other unpasteurized milk during pregnancy, then there are very high chances that the newborn baby will have either meningitis or granulomatous diseases like infantiseptica. It shows jet actin motility by using host active fibers. Jet actin motility by using host active fibers. Treatment is what? Uh, Treatment is ampicillin and gentamicin. We read in the morning. Anton test is the diagnosis. Method of diagnosis, it is not used now. So Anton test is when you are going to inject it into the eyes of the rabbit, and that is going to cause keratoconjunctivitis. And this method, this crude method, is no more used. Okay. Now we are going to move to Mycobacterium Tuberculosis. So TB is a huge topic, and I guess Mycobacterium bovis, then atypical Mycobacteria, and then gram-negative will come. So, Mycobacterium tuberculosis, where is this? Yes. This is Listeria monocytogenes meningitis was being caused by this. If there is pharyngitis or tonsillitis, that shows that the patient is suffering from UIP. LITI will. So before wasting any more time, let's move to Mycobacterium. There is Mycobacterium. 345 page number. Mycobacterium tuberculosis. Clinical case 1. A 50-year-old man presented with a history of low-grade fever with evening rise in temperature. Okay. Low-grade fever, evening rise in temperature. And productive cough. Okay. For the past 2 months, the patient had productive cough. He sought medical advice as in the previous 3 days he had started coughing. He sought medical advice as in the previous 3 days he had started coughing blood-tinged sputum. His history revealed loss of appetite and weight loss of 5 kg over the previous 12 months. In the chest X-ray, nodular infiltrate was seen in the apical area of the right upper lobe. This is a right side ka upper lobe. So a nodular infiltrate was seen in the apical area of the right upper lobe. Okay. Sputum smear was positive for AFB and his culture was positive for tuberculosis and he was started on DOTS therapy. Fine. Now second clinical case, a 27-year-old man complained of low-grade fever and mild headache for the previous 2 weeks but came to the hospital because of worsening of his headache over the previous 2 days. He also had a vomiting, confusion, stiffness, and maybe TBM. He was HIV positive. Okay, Cryptococcus Uridines. Let's see. His CSF, not Cryptococcus. His CSF examination showed mild increase in the counts, but with predominant lymphocytes were predominant. Okay, predominant lymphocytes, not neutrophils. Proteins were raised, glucose was low. It's definitely bacterial meningitis. CSF was negative on direct smear examination by ZN or gram stain. Okay. PCR was positive for Mycobacterium tuberculosis. Okay. And after 2 weeks, the culture by automated system was positive for this organism. Okay. Automated is CB9. Drug sensitivity test showed that the strain was resistant to rifampicin and isoniazid. Okay, so it is MDR. He was treated with second line drugs and improved. Injectables maybe, but developed residual paralysis of the left lower limb. So, okay, residual paralysis of the left limb. This can be a case, can be of analysis. Moving on, Mycobacterium tuberculosis causes white plague, captain of men's death. This gram positive, acid fast, non-motile. Mycobacterium tuberculosis complex has Mycobacterium tuberculosis, Mycobacterium bovis, microchae, and africanum or africanum. Now, Mycobacterium tuberculosis versus Mycobacterium bovis. Okay. Mycobacterium tuberculosis में क्या होता है? Zn staining, irregularly stained and beaded appearance. Okay, fine. It is irregularly stained. Okay. LJ medium में rough, buff, tough colonies, cauliflower colonies. Fine. Positive for niacin, neutral red nitrate reduction test. Obligate error, glycerol, if added, is going to increase the growth. Whereas bovis is regularly stained, they are slender, they are going to produce very creamy, smooth colonies. Niacin, neutral red, and nitrate reduction test is going to be negative. It is what it is microaerophilic, not obligate anaerobe, but it is microaerophilic. Requires less oxygen. Glycerol increases the growth and glycerol is going to decrease the growth. Virulence factors are lipoarabinomannan, cord factor. Cord factor is actually 7H9 serpentine forms are produced. So middle group भी कहते हैं. Mycobacterium heat shock protein or MHSP. Lab diagnosis is the sputum microscopy. Okay. Atypical भी है क्या? Atypical का clinical scenario कोई दिया? Leprosy का भी नहीं दिया. Just have to see the images. Please go on reading. Lab diagnosis is what? Sputum microscopy. So, see, this will come to last till 8th month. Method of finishing system in bacteriology. Lab diagnosis is sputum microscopy. A is a spot sample, B is a morning sample. Okay. A is spot sample, B is morning sample. Zn stain में auramine and rhodamine stain. Okay. Auramine and rhodamine stain will be given. Lab diagnosis is sputum microscopy, spot sample, morning sample. Zn staining is by auramine and rhodamine stain. And morning sample, spot sample, culture. Culture will be gold standard. It will be either solid culture or liquid. Solid may you will have egg. or LJ or Dorset based. Okay, solid egg, LJ or Dorset based. Serum based is what? Loeffler serum slope. Blood is Tarski's medium. So culture, gold standard, solid culture and liquid culture. Solid culture, egg based will be Dorset and LJ medium. Serum will be Loeffler serum slope and blood will be Tarski's medium. Loeffler serum slope हमने और भी कहीं पढ़ा है, अभी ही पढ़ा है. क्लॉस्ट्रीडियम में पढ़ा है क्या कि कोराइनी बैक्टीरियम है? कोराइनी बैक्टीरियम में पढ़ा. Then comes 6 to 8 weeks का टाइम चाहिए होता है to grow in a solid culture taken for the growth of bacteria. अब इतने दिन का इंतजार is very difficult. Liquid is what? MGI, it is Mycobacterium growth indicator tube. Mycobacterium growth indicator tube is what MGIT means. Mycobacterium growth indicator tube. Middlebrook or 7H9 medium is used. Remember, cord factor. Mycobacterium growth indicator tube. इसमें the time taken is 3 to 13 days for growth. Serological test is IGRA, quantiferon gold, and TB dot. These are the tests that will be done. IGRA, quantiferon gold, TB dot, TB spot, and ELISA. These are serological tests, but serological tests are not done now. Why they are not done? Because they are making people false positive. Okay? Everyone becomes positive. Why? Because and so everyone will be treated once a positive case has to be treated, has to be given dots. That is there in the guideline. And because of this, there was a lot of drug resistance. Okay, so serological tests are not done now. Everyone will become positive. So to avoid drug resistance, we don't do. Now, drug resistance is MDR TB, XDR TB. MDR TB में it is isoniazid and rifampicin resistance. Okay, isoniazid and rifampicin resistance है अगर तो that is MDR TB. XDR is MDR plus rifampicin plus one of the second lines, that is fluoroquinolones or injectables like kanamycin, capreomycin, amikacin, etc. Fluoroquinolones, yes. Now, gene export. What is gene export? Gene export is a method to detect drug resistance in TB. The time taken for by the gene expert or to know resistance is just 2 hours. This technique is based on PCR. Okay, this technique is based on what? It is based on PCR. Okay, line probe assay is 6 to 8 hours. Line probe assay takes 6 to 8 hours, whereas gene expert takes just 2 hours. Dots. Dots these days are being given as a daily regimen and before starting ATT. Dots these days are being given like a daily regimen. Okay. Dots these days they are being given as what? They are being given as a daily regimen. Dots these days are being given as a daily regimen. And before starting ATT based on antibiogram is done to differentiate whether to give first line drug or a second line drug. So dots these days are being given as what? As daily regimen. Okay. How is dots given? Dots these days is being given like a daily regimen. Daily regimen dots will be given. Before starting ATT based on antibiogram is done to differentiate whether to give first line or second line. Now, atypical mycobacterium is also known as non-tuberculous mycobacterium, also known as Mycobacterium other than tuberculosis, also known as environmental mycobacterium, and it is based on the pigment production. There was one classification, Runyan's classification. Runyan's classification says that photochromogens. Now, pigment is produced in the presence of light. The way of remembering is that M.K. Gandhi showed us light, that is Mycobacterium kansasi. Then Gordon, why is not Gordon in it? M.K. Gandhi. Gordon was also a, no, Gordon also shows light. This photochromogens they only produce in the presence of light. So kansasi, marinum, and asiaticum. 6 to 8 weeks are required to grow this. Scotochromogens, pigment is produced even in the presence of darkness. Okay, the pigment will be produced even in the presence of darkness. That is also, but in light also they produce. So darkness may be produced करेंगे Gordone, Scrofulatium, and Zulgai, Scrofulatium, and Gordon. Non-chromogens, that is no pigment produced either in the light or in the dark. These are all vowels. Okay, A, avium, intercellulare, ulcerans. Okay, even xenopsy is also like that. Rapid growers are what? Chelone, fortuitum, and spegmatis. Pigment produced and non-pigment producers among rapid growers. Now, they require 1 week to grow, rapid growers. Now, those which produce pigment, they are spegmatis and flail. Those which do not produce is chelone, fortuitum, and abscess. They are not going to produce pigment. Now, endoscope contamination. Endoscope contamination is generally by chelone. Now, there is a very funny way to remember this. When I had a Pomeranian pet, that time these pets they have a tendency to have lot of ticks on their body, and in Hindi, the word for ticks is khilone, which doesn't they are so adherent to the skin or to the fur of the animal that they are very difficult to retreat. So, in the same way, endoscopes. So, I assume that just like when endoscopy is done, the probe, something would be adhered to that. Okay, and that is why the name Kiloni is there. Okay, hospital outbreaks or nosocomial is by xenopsy. Xenopsy was in non-chromogen. Something that mimics TB is Kansasi. Buruli ulcer is ulcerans. Fish tank granuloma or swimming pool granuloma is M. marinum. Okay. Battery bacillus is intercellulare. John bacillus is paratuberculosis. Now, atypical mycobacterium, it is positive with the following tests: AAT, amylase, aryl sulfatase, and thermocatalysis. Atypical catalase activity will be seen at 68 degrees, whereas in the case of typical, it is seen at 37 degrees Celsius. Okay. Treatment is rifampicin plus clarithromycin or azithromycin plus amoxiclav. So all these can be given. Now, Mycobacterium leprae. Mycobacterium leprae is also called as the Hansen's bacillus. Okay, Hansen's bacillus is Mycobacterium leprae. It is weakly acid fast. A cigar bundle arrangement होता है इसका. Okay, Hansen's bacillus is Mycobacterium factor. Mycobacterium leprosy. Oh God, I'm so tired now. Mycobacterium leprae. Hansen's bacillus, it is weakly acid fast. Let's see in 1 hour what we can do. Maybe we will finish this, but not Enterobacteriaceae. Oh. Hansen's bacillus, it is weakly acid fast. Okay, 5% H2SO4 is there. M. leprae, Hansen's bacillus, weakly acid fast. There they have 5% H2SO4. Good for them. Cigar bundle arrangement. Phenolic glycolipid 1 is the virulence factor, and that is actually lipoarabinomannan like. Droplet infection, direct contact with the broken skin. 9-banded armadillo is the best foot pad of mice. The organisms that are used to grow this, so this can be grown in animal models. Other animal models are also used. Pretty bonita leprosy. It is a rare and severe form of LL leprosy that generates a moist and myxedematous complexion. Myxedematous complexion, and imparting a very healthy aspect to the patient. Slit skin smear is the method of diagnosis. There should be 4 to 6 sites are the sites from where the specimen is taken. The treatment is what? Multi-drug therapy is the treatment. Okay. Now, lepra reaction. Yes, lepra reaction 3. Okay, wait just a second. See, Leprometus leprosy, the resistance of the body is low. Infectivity is high. So bacilli in the skin will be high. Bacilli in the nasal secretions will also be high. Granuloma formation, yes, there will be. Lepromin test will not be that sensitive, so it will have low sensitivity. Antibodies to M. leprae is hypergamma-globulinemia, and prognosis of such patients will be poor. Okay. Now, lepromin early and late. Early में क्या होता है? Early Fernandez and late is having Mitsuda reaction. Early lepromin test result is Fernandez 2 to 3 days, and Mitsuda reaction is 3 to 4 weeks. Fever. Okay. And the etiological agent. Sudoku fever. Sudoku fever is due to spirillum minus. Okay. Brazilian purpuric fever is due to Haemophilus aegypticus. Oroya fever is due to Bartonella bacilliformis. Then Haverhill fever is Streptobacillus moniliformis. Haverhill fever. Pontac fever is Legionella. Scarlet fever is Streptococcus pyogenes. Trench fever is Bartonella quintata. And Senexic fever is by Ehrlichia. Okay. So many types of fevers, my God. Then comes lepra reaction. Lepra reaction जो है lepra reaction 3. It shows Lucio phenomena, type 3 hypersensitivity reaction. Okay. In this, there is erythema necroticans. It is not responsive to steroids. So this finishes our Mycobacterium, atypical Mycobacterium, and also leprosy. Quickly going through two flip pages, and then I'm going to go for nocardia and also for actinomyces. So first was scenario. The thing is Mycobacteria on LJ media left and LJ media without growth. Okay. This is the nitrate test. No change with alpha naphthalene and sulfur acid nitrite absent, turns red with alpha naphthalene sulfur acid nitrite present. Phos reduction nitrate test. No change with zinc. Phos nitrate reduction test and turns red with zinc. Negative nitrate reduction test. Okay, fine. Not something very. Oh God, I'm so dead. Tubercle or granuloma with caseation. Caseation. Mycobacterium tuberculosis, acid fast bacilli, it's not uniform, stained uniformly. Growth on LJ medium for tweetum. ये देखो Mycobacterium leprae, acid fast pink bacilli with typical globi arrangement. ये भी leprosy है, Leprometus leprosy with abundant bacilli. And इसमें कम है, that is tuberculoid with scanty bacilli. Yes. There was one question in narrow that I had solved, and it was about Bacteriological Index. The spheres are graded based on the number of bacilli as follows. अगर 1 से 10 bacilli हैं 100 field में 100 field तो 1 plus. 1 से 10 bacilli 10 fields में है तो that is 2 plus. If 1 से 10 bacilli per field में है then 3 plus. फिर 10 से 100 बैसिलाई पर फील्ड में है तो 4 प्लस, 10 से 1000 बैसिलाई हैं पर फील्ड में तो 5 प्लस, एंड मोर देन 1000 बैसिलाई या क्लम्प्स हैं तो 6 प्लस, and the globi in every field. Now bacteriological index is calculated by totaling the number of pluses scored in all the smears and divided by the number of smears. Thus, if 8 smears were examined and they have a total of 16 pluses, then the BI will be 16 by 8, that is 2. For calculating the BI, a minimum of 4 skin lesions, a nasal swab, and both ईयर लोब्स हैव टू बी एग्जामिन्ड. तो एक तो दोनों ईयर लोब्स नाक से और स्किन, मिनिमम ऑफ 4 स्किन लीजन्स, दिस शुड बी देयर. ठीक. So now you should not do this wrong. Okay, now you have understood कि कैसे ये calculate हो रहा है. Okay. Yes. There is something about prophylaxis that I want to study. Acha. Case finding inadequate therapy, long-term prophylaxis, BCG vaccine. No specific vaccine is available since there is some degree of antigenic relationship between lepra and tubercle bacilli. Field trials with different leprosy vaccine, BCG, kill lepra vaccine, and ICRC bacillus were conducted but without conclusive evidence. Okay. Chalo. This finishes. Now nocardia. Nocardia and what? Nocardia and actinomyces. Oh my God. Bartonella punctata causes sponge fever. Orola basilicans. Contact fever किससे हो रहा था? Contact fever was with this Legionella. Legionella. Legionella पे हमने नहीं किया है. Let's quickly move to why is nocardia not given in this? This actinomycetes must be given. Yes, nocardia is this. I remember I studied nocardia very nicely. Actinomycetes. Okay. So I'm going to do first actinomyces because I have a clinical case here, and then I'm going to move to nocardia. Actinomycosis. Clinical case 1. A 20-year-old woman, 20-year-old, like young woman, presented to the surgery OPD, oh my God, with a soft tissue swelling in her left jaw. Left jaw is swelling here, which was painless and it is covered with exudate, okay? On examination, a discharging sinus was found, okay? She had history of trauma to the area, okay? The pus was sent for culture test on macroscopic examination. Sulfur granules, yes. Come on, all these things clinch the diagnosis to actinomycosis. We read about this in Derma. The gram stain of the granule showed the presence of branching, that is gram positive bacilli. Showed the presence of branching gram positive bacilli. Fine. The patient was diagnosed with cervicofacial actinomycosis and responded to treatment with penicillin. Presence of branching. Okay, gram positive bacilli. Okay. Patient was diagnosed with cervicofacial actinomycosis and responded to treatment with penicillin. ठीक है, चलिए देखते हैं क्या है. ग्राम पॉजिटिव बढ़िया. फिलामेंटस ओके. नॉन एसिड फास्ट. एसिड फास्ट नहीं होते हैं. एनारोब ओके. एनारोबिक फाइन फाइन. एनारोबिक. एंडोजिनस and they are the part of normal flora. Causes cervicofacial actinomycosis, exactly same thing that we just studied. Most common cause of PID in people using intrauterine device as contraceptive is disease. Then produces produces culture में spidery molar tooth appearance. Oh God, molar tooth appearance colonies. Remember? Yes. And microscopy में it is going to show samurai appearance. Okay. Treatment is penicillin. Treatment will be penicillin. Now, sulfur granule section in HNE stain. This is what gram-positive filamentous bacilli in pus. Acid fast नहीं होते. ठीक है. मोलर टूथ कॉलोनीज कहीं नाम लिखा हो. स्पाइडरी कॉलोनीज तो लिखा है. मोलर टूथ कॉलोनीज नहीं लिखा है. कोई बात नहीं, हमने पढ़ लिया. चलो, नोकार्डिया. नोकार्डिया देखो क्या है. 60-year-old patient, 60-year-old HIV positive man developed pneumonia, okay, with high-grade fever and productive cough. T cell, that is CD4 count, was less than 200 per millimeter cube. See, when such situation comes, quickly don't attack pneumocystis jirovecii pneumonia. Okay, please wait. Then, the initial diagnosis of pulmonary TB was subsequently ruled out by laboratory tests. Fine. Then, further examination of sputum showed the presence of fine, very fine, right-angled branching filaments which were acid-fast by modified technique. Culture on blood agar showed the growth of a dry, buff-colored colonies identified as dry buff-colored colonies. Buff color is slight light pink, Identified as N. asteroides. The patient responded to treatment with cotrimoxazole and amikacin. See, this is what? Acid fast, weakly acid fast, exogenous, produces pulmonary nocardiosis, especially in HIV patient. Orange to yellow colored colonies. Paraffin bait method is used to trap the organism. Paraffin bait method, fine. That is all about it for time exercise. They have given very less of this. Positive for quinine acid fast and weakly acid fast section. Yellow to red देखो है. और अमीका ठीक. यूमाइकोटिक माइसेटोमा का ब्लैक होगा ग्राम में. फार्मर्स स्ट्रांगली प्रोड्यूस करते हैं. gram negatives, I am this much close to just stop studying, but let's see how much we can go. A general introduction of all the gram negatives. Gram-negative cocci, gram-negative bacilli, gram-negative cocci are Listeria. Listeria, they are gram-negative diplococci and they are oxidase positive. Gram-negative bacilli, they are differentiated on the basis of oxidase positive or negative. Okay, but gram-negative cocci, they are always oxidase positive. Okay, gram-negative bacilli, they can be positive or they can be negative. If they are negative, then they come in the category of Enterobacteriaceae, oxidase positive, gram-negative bacilli. That is a separate entity where Salmonella, all this, Shigella, E. coli, all these things we are going to study there. If they are oxidase positive, okay, then we need to see in terms of oxygen requirement what kind of bacteria they are. For example, if they are obligate aerobes, then they will be either Bordetella, Brucella, Legionella, Pseudomonas. Bordetella, Brucella, Legionella, Pseudomonas. Okay. Facultative anaerobes. Like कभी कभी हम बिना ऑक्सीजन के भी रह लेते हैं, कभी कभार वाले शौकिया वाले हैं, ऐसे हम नहीं रहते हैं. That is facultative anaerobes like Vibrio, cholerae and Haemophilus influenza. Then microaerophilic. Okay, microaerophilic like less oxygen. They are H. pylori and Campylobacter jejuni. Okay. Now let's move ahead. Listeria. So before starting Listeria, let me open the chapter of Listeria. Gonorrhea. I'm so tired. Listeria. Clinical case. A 7-year-old boy presented to the emergency department with high-grade fever on the previous day. He complained of headache, was disoriented, and had projectile vomiting. Okay, so sad. 7-year-old boy presented to the emergency department with high-grade fever on previous day. Fine, complained of headache, disoriented, projectile vomiting. On examination, neck was rigid, chronic sign positive, lumbar puncture was carried out along with complete blood counts and serum biochemistry. Cytology showed polymorphs at 10 to the power 3 per millimeter cube. Polymorphs. Protein 250 mg per deciliter and glucose 20 mg per deciliter. Clearly, glucose is less over here. Then blood glucose levels were, glucose was this. Glucose levels were normal. Oh my god. And then on gram stain, blood glucose was normal, not CSF. CSF to come here. Then on gram staining, gram negative cocci were seen in pairs, most of them inside polymorphs. Okay. Later, agglutination test was positive for Neisseria meningitis antigen, confirming the diagnosis of meningitis. The patient responded to antimicrobial treatment. Fine. Vaccination was advised for the patient's siblings along with chemoprophylaxis. So, see, diphtheria में भी हमको देना था बच्चे को, उसके close contacts को, and also in meningitis. Okay, both you should give. Okay. Oh my god, this is becoming very. Okay, meningococcal and gonococcal we are going to do together. So I am going to read the case scenarios for both. Now, a 20-year-old man presented with urethral discharge and dysuria for the previous 2 days. His history revealed that he had had unprotected sex with a commercial sex worker 7 days before. Very bad. On examination of a smear of the pus, gram-negative diplococci were found inside polymorphs. Okay, gram-negative diplococci was found inside polymorphs. Fine. The culture on Ther-Martin medium was positive and a diagnosis of gonorrhea was made. Okay, gram-negative diplococci were found inside polymorphs. Mm-hmm. Ther-Martin, okay, positive. Diagnosis of gonorrhea was made. The patient responded to suitable antibiotics. Okay, so that's how it is like. So, Listeria. Going for Listeria now, and then we will go for Vibrio. I am so much confused in Vibrio cholerae and parahemolyticus. Let's see how it turns out. Neisseria. Neisseria is gram-negative diplococci. That's something that occurs in pairs. It is oxidase positive. Okay. Gram-negative diplococci existing in pairs. Gram-negative, yes. Gram-negative diplococci existing in pairs. Oxidase positive. Conococcus is kidney shaped. There is no capsule, only glucose. Conococci is kidney shaped. It does not have any capsule and they use only glucose. Pili is the virulent factor over here and they are generally intracellular. So before that, yes. Pili is the virulence factor और उसमें क्या होता है P1, P2, P3. P1 is for, P2 is OPA, P3 is RMP. P1 is for it prevents phagolysosome formation. ठीक? It prevents what? Phagolysosome formation. P2 is OPA, invasion. And P3 is RMP. It blocks the bactericidal antibiotics against P1 and LOS. And LOS is inflammatory response and triggers the release of TNF, glycooligosaccharide. So these are all virulent factors that are found. So they prevent phagolysosome formation. Then meningococci. Meningococci is lens-shaped, okay, D की तरह होता है. Capsule is not present. Okay, capsule is not present in these. Glucose is used. इसमें maltose and glucose both are used and both they are fermented. Maltose and glucose दोनों use करेंगे and they will be fermented. Capsule is going to be formed. And intracellular or extracellular, so it is extracellular. Okay. I might just stop after this event. I'm not feeling nice now. Intracellular, it is meningococci is extracellular. Okay. Now, gonococci. Selective medium, modified Ther-Martin medium and modified New York City medium and what GC. GC wheat medium. Thayer Martin, New York City, and GC what medium? Please check. Mueller Hinton agar है. Chocolate agar Mueller Hinton agar. Thayer Martin. Nothing as such given. Maybe it's chocolate agar. Virulent factors क्या क्या होते हैं? T1, T2 pili. T1, T2 pili में लाइपो ओलिगोसैकेराइड जो कि क्या TNF रिलीज करते हैं, हाँ, और IgA प्रोटीएज. ओके. नाउ डिजीज जो है मेल्स में इट कॉजेज यूरिथ्राइटिस और डिसयूरिया. It causes urethritis and dysuria. Urethritis and dysuria. Complication is what? It causes water can perineum. Males. Females में pelvic inflammatory disease, endocervicitis, septic arthritis, rash also, perihepatitis, Pitt-Herd-Curtis syndrome. Yes, remember? Lab diagnosis in male is urethral discharge. In female, you are going to take the endocervical swab. Gram stain is sufficient to diagnose, and for that, no culture is needed. Drug of choice is ceftriaxone plus azithromycin. Penicillinase producing NG was caused when penicillin was used earlier. Non-gonococcal urethritis अगर penicillin यूज कर दिया था, इसलिए ceftriaxone और azithromycin. Children में neonate में ophthalmia neonatorum हो जाता, prevention is by Creed's method. GNO3 यूज करेंगे, treatment is by ceftriaxone. Now meningococci. Thayer Martin again polysaccharide capsule. होता है serotypes A, B, C, E, W135 and Y. Now LOS is lipo-oligosaccharide, pili, IgA, protease. These are other virulent factors. What is the spread? Spread is the hematogenous spread is from nasopharynx to the brain. Hematogenous spread will be from nasopharynx to brain. Done. Hematogenous spread will be from nasopharynx, remember, nasopharynx to brain. Done. Causes petechial rash or petechial hemorrhages, bilateral adrenal hemorrhages, fulminant meningococcemia, septic shock, DIC, and death. This is what is called as Waterhouse-Friderichsen syndrome. Rash, adrenal hemorrhage, meningococcemia, fulminant, septic shock, DIC, death. Now, meningitis in adolescents to adults in people with decreased C5b9 deficiency, pyogenic meningitis. Lab diagnosis CSF में antigen detect कर दो. Drug of choice is ceftriaxone and also chemoprophylaxis has to be given. Vaccine is a tetravalent vaccine is given. Less than 2 years पे conjugate, more than 2 years पे polysaccharide vaccine, and tetravalent is what? ACWY vaccine, something like that. Let's quickly see the images. Okay, this is what? This seems to be meningitis. Okay, this is Neisseria meningitis, Schwein diplophoca. Prophylaxis is ACWY actually. Tetravalent vaccine. Listeria gonorrhoeae में Stewart transport medium create होता है for gonorrhea. Vaccination has no place in gonorrheal infections. Okay. So if we see the list, staph done, strep done, strep pneumoniae done, Neisseria done, Corynea done, Bacillus done, Clostridium done, non-coding anaerobes, Proteus not done, Shigella salmonella not done, Vibrio not done, Shigella not done. So many deaths was there. This done, this done, this done. Actinomyces done. Okay, among miscellaneous bacteria, it is Listeria and Mycobacterium that is also done. So with this, I am going to end this session because I am utterly tired. Utterly tired. Okay. 12 more minutes will be around 17 and 17 8 hours 20 minutes almost.